Coming to the operative treatment, osteochondritis dissecans usually does not require a lot of operative treatment, but in certain situations, for example, if there is failed conservative treatment, or for example, the physis is closed, or there's young adult who has not responded well to the treatment, or the patient who's old age and has developed this problem, usually require operative treatment. Now there are multiple options for the operative treatment, which may involve from simple microfracture technique to osteochondral autograft, osteochondral allograft, autologous chondrocyte implantation, and all these options are available. This could be arthroscope assisted or arthroscopically. This can be done along with the orthotomy. We can open the joint up and do it with the open procedure as well. But what is important to understand is that as a clinician, you need to first make the diagnosis, get the X-rays and MRI done, and we actually decide how much the large is the lesion. Is the lesion is small enough or large, and whether the lesion is stable or unstable. What is going to dictate your treatment or options is going to be either the lesion is more than 2 centimeter or 2 to 3 centimeters square, or lesion is less than 2 to 3 centimeters square of area, and whether the lesion is stable or unstable. Usually large lesions who are more than 2 to 3 centimeter and unstable, you require an arthroscopic, either autologous or a allograft, osteochondral allograft. But they may also require autologous chondrocyte implantation as well. But with the small lesions, all you need to do is actually the microfracture technique and do osteochondral autograft may be enough as well. So the first technique is usually you have to go with the diagnostic arthroscopy. Why you need to put the scope in? Because we have done the MRI, we know whether it's stable or unstable, and if it comes out to be an unstable lesion but it's actually Clanton type 3, that it is not detached, it's completely detached but it's not has gone into the joint. Therefore we have to go for arthroscopic diagnostic arthroscopy and do some sort of a fracture fixation or kind of a fragment fixation, which may need be required as well. Therefore, once usually you go in for a diagnostic arthroscopy, whatever you have found out on history examination, X-rays and MRI, then you go for a planned arthroscopy, and you mostly go in arthroscopically and do your management over there as well. And most of the time the fixation of the fragment is done arthroscopically nowadays by using hybrid screws, pegs, and all these options are available. Other option is subchondral drilling with K-wire or drill. This is called as microfracture technique or subchondral drilling technique. Usually what has happened is, if you see, this is the subchondral bone, this is the cartilaginous lesion, and on this side you have a joint, and this is the subchondral side of the bone. What happens is that part of the cartilage is actually torn up or gone out. Therefore this is subchondral bone is actually exposed. You will have this subchondral bone, and then you will have actually intramedullary cavity of the femoral condyle on this side. You drill in as long as you reach the intramedullary cavity, and then you go back out. You can do multiple holes in this area. This is called as creating microfractures or multiple fractures by use of a drill bit or even use of a K-wire as well. K-wire is a bit smooth, and when we are actually doing this, especially with the physis open, you cannot do this with the drill bit, because that is going to damage the physis as well. So when we are doing in children who have open physis, we may have to use smooth K-wires. But if we are doing it in adults which physis is already closed down, then probably we don't need to really worry about the damage to the physis. Therefore we can use a drill bit as well. But technique for the both K-wire or drill bit is usually the same, that you drill as long as you reach the intramedullary cavity and then go back out. What happens is, because there is intramedullary cavity over here, once the track has been formed all the way up to the subchondral bone, the intramedullary cavity, there will contain a lot of stem cells which will flow all the way back in, and this cartilage usually is high in cartilage, but a fibrocartilage may be formed as well, which actually covers the subchondral bone and helps in the healing. So this is the basic mechanism, that although we cannot regenerate hyaline cartilage, but a fibrocartilage which actually gets formed over the lesion where it was, and this actually helps in the healing and the symptoms usually disappear. This is basically the science behind the microfracture technique and subchondral bone. Now other options is that what is actually the mechanical science behind the use of drill bits or K-wires. Usually, as you know, these drill bits or K-wires are cylindrical objects, and cylinders have their own axis as well. So there is a angle called as helix angle, is actually between any helix and the cylinder of axis. If you imagine this as one cylinder of this without use of any flutes are actually rivets and crevices which actually are produced in the cylinder, so that it actually helps in increased cutting of the drill bits, and this makes it more easily makes the cutting of the drill bit more easily, and so that it can easily rotate and go back into the bone. And the angle which is actually subtended by the cylindrical axis and the helix is formed is called as the helix angle. There is multiple different trocars and drill bits are available. This could be as simple as smooth trocar, on which you cannot appreciate any teeth of it, and there is only one simple sharp edge and it goes back in. Other is smooth diamond cutting, because the way they cut the bone is actually different. For example, they cut it in a triangular fashion, they can cut it in a straight line as well. Therefore, this is smooth diamond. Other, it could be threaded as well. This is smooth trocar. This is actually trocar with the thread only, and it's a straight cutting trocar. But there could be this way as well, in which there's threaded diamond cutting as well. The only difference is with these crevices and flutes and cutting edges, it helps is that they're self-cutting. So when you put it in, they cut the bone as they go in. For example, in a normal fashion, if you are putting in a trocar which is not self-cutting, therefore first you have to cut it with the drill and then put the trocar in. So mostly these trocars are self-cutting, so as they go in, they cut the bone and create a space for themselves. So this is basically these threads actually help them to go for this sort of a procedure. This is just the diagram which is actually showing how these flutes actually help to make the cylinder cut different. And this is the point angle and helical angle which has been subtended, and this is, if it's kind of threaded, this is how the flutes are, and this is how they cut around. If you see, this is a smooth trocar, it's going to cut like this. Diamond trocar is going to cut like little differently, because this is the cutting edge. With threaded trocar, is going to cut like this, but it's going to go in along as it's going to cut. And with a threaded diamond, is again going to cut like this, but it's self-cutting, so it's going to cut the bone and go in as it's not smooth, so you don't need to push it in with the use of any machine, but all it's going to go in with the chuck as you move it into the bone. Now coming to fixation of unstable lesion. If on X-ray and MRI we know the lesion is unstable, that is, for example, lesion is Clampton type 3 or Clampton type 2, this may lead to, for example, if you see it over here, this is an X-ray. Can you appreciate this very small lesion on the medial femoral condyle? This is the same view with the lateral view, and you can appreciate the crater over there, increased sclerosis, but although there is no lucency around it, so probably it's not completely separated, it's still lying there and it's relatively stable. Same patient's MRI, you can appreciate it over here, and MRI is actually telling a better story, that you can appreciate the whole of the subchondral bone is actually separated, but this fragment is undisplaced. Therefore, this lesion is unstable. At this moment, has not actually moved out into the joint, but if it continues for a little longer time, probably from type 3 it can move into type 4 and eventually become displaced. So these unstable lesions can be fixed arthroscopically, or even orthotomy can be used as well, that you can open the knee joint and do put in a Herbert screws or peg as well. But nowadays the most common technique is to go in arthroscopically and put in a Herbert screw, is actually a headless screw, Therefore, once the screw is in, you don't have a head which is actually lying into the joint. Therefore, these Herbert screws or pegs, osteochondral pegs, can be used to actually fix these unstable joints as well. This is one of the arthroscopic views which is actually being used. First, the drill is being done where the problem is, and then you can put in the Herbert screw as well. And these are the headless screws, therefore the actually heads are not protruding into the joint. And this is the way we can fix the unstable lesion of the osteochondral dissecans. Another technique is chondral resurfacing. If you can appreciate in this diagram that this is subchondral bone, and on the top of it you have a calcified cartilage, and there's a hyaline cartilage which actually lines the joint. The problem is with the hyaline cartilage, it gets eroded and subchondral bone gets exposed. Therefore, due to microtrauma at that area, this leads to formation of osteochondritis dissecans. Now, if it's a small lesion, less than 2 to 3 centimeter lesion, we can go for this technique that is called as chondral resurfacing. We use an arthroscope to actually shave off all the area, and all the pathognomic or pathological actually the cartilage is removed, and then we use microfracture techniques to actually drill through the subchondral bone and allow it to wait for the fibrocartilage to appear. And once the area which has actually been gone from the hyaline cartilage, this is formed by the fibrocartilage, and this is called as chondral resurfacing. This is one technique. But if all these techniques fail, then we have always options available in form of a knee arthroplasty. And why we go for knee arthroplasty? Because osteochondritis dissecans usually produces early osteoarthritis of the knee joint. Especially in the case of adults, it may lead to early osteoarthritis, and eventually arthritis may be severe enough that we may have to go for knee arthroplasty. And knee arthroplasty may be required. It could be usually hinged or non-hinged, or it could be posterior stabilized, or it could be even the cruciate retaining arthroplasty as well. But mostly it is always the cruciate retaining or posterior stabilized knee arthroplasty which is usually done in these cases, because overall the ligaments and the knee mechanics is very much intact, but the problem is with the subchondral bone and the arthritis which may have developed over the period of time due to osteochondritis dissecans. So whenever we are doing for the operative treatment of the osteochondritis dissecans, we have all the options available, right from the microfracture technique, using drill bits, K-wires, stabilizing the unstable lesion with use of Herbert screws, pegs, even chondral resurfacing, autogenous autograft or allograft, or use of knee arthroplasty as well.